The talk that I'm going to give you today is about, it's a combination of both some basic carotid ultrasound information as well as the pitfalls that we find when we're doing it. What? Oh, okay. So when we get down to asking why do people do carotid ultrasounds, indications for carotid ultrasounds, we know they're done for transient ischemic attacks, for acute strokes, but in particular a couple interesting reasons that we have it at the VA recently. We've been doing a lot more of them on all of the coronary artery bypass graft patients. They all get a pre-op carotid ultrasound, and not infrequently they wind up going to the operating room and having both the carotid endarterectomy and the coronary bypass at the same time. The carotid's done first to protect their cerebral blood flow when they're on the cardiac pump. So that's one of our other indications for carotid ultrasound. And another reason, one that we've been doing a lot of, is intraoperative carotid ultrasound directly on the naked carotid artery opened up in the endarterectomy site. But as you all know, there's been these two large studies done to try to evaluate whether or not carotid endarterectomies can actually produce a reduction in stroke. And the first one that you've probably all heard about is the NASIT study, the North American Symptomatic Carotid Endarterectomy Test trial. And the other one is one a little bit more recent than that, which is the asymptomatic carotid atherosclerotic study. Now, as you know, the NASIT found that carotid endarterectomy actually produces an absolute reduction of 17% in strokes at 2 years when compared with medical therapy. Oops, something went off here. The screen went out here. Mike, the screen's out here. I don't know what happened. Your screen's out. It's working, but I have nothing to see. Okay, I don't know what happened here. Your screen went out.
Do you want to just use that one?
I guess so, yeah. Move me back a couple more slides, I guess. Okay. Back yet. Okay. Well, I was hoping to not have to use my glasses, but I guess I'll have to. Anyway, the NASIT study also showed that there was an improvement in the people, the 17% improvement in the number of strokes in 2 years when compared to medical therapy. And this was for people who had stenosis of greater than 70%. But NASIT also looked at an improvement in the outcome of the patients with endarterectomies in an earlier category, the 50 to 69% stenosis. And they also showed an improvement of only about 6%, but still an improvement. And as you know, this trial was stopped early because of this information. They felt it was not justified to keep continuing putting people into the medical therapy arm. So the next thing that was done was to look at whether or not this kind of improvement in stroke reduction could be found also in the asymptomatic patients, and that's what the ACAS study showed also. They showed a reduction, again, of about 6% over a 5-year period in asymptomatic patients with a 60% stenosis. So because of this, screening for patients with carotid ultrasound has become very important, because even asymptomatic patients may benefit from having endarterectomies preventively. The criteria that we use for carotid ultrasound, the primary criteria is velocity, peak systolic velocity in particular. But in addition, we have other things that we can use during the study, such as grayscale or B-mode imaging, color Doppler mode, and power Doppler mode. And we're going to talk about each of these. In this first slide here, I wanted to show you, this is a power mode examination. It's of a right carotid bulb. And as you can see from this power mode one, there's no color bleeding out over the edge of the vessel, and it looks like a fairly decent looking bulb and ECA. But this is exactly the same slice with the color mode turned off, and you can see there's a fairly sizable a plaque in there. right here. You've got this chunky plaque in there, and then we have this big calcified plaque causing acoustic shadowing back there, all hidden by the color mode. So one of the first things I wanted to talk about was the use of power Doppler. I'm not a fan of power Doppler, except in the case that it shows you flow or no flow. It is, of course, color Doppler, and it shows average velocity, and it shows no direction of flow. And I've seen it many times actually covering up significant pathology. What we reserve that for is looking for flow or no flow, particularly in a patient who may have a pre-occlusive stenosis, and we want to make sure there's any flow at all, a slight string sign, which will still keep them to be a candidate for endarterectomy. Now this is that same patient, and you can see this patient on routine color Doppler. You can see that plaque nicely. And of course, it's very important. Again, in ultrasound, you've heard it a million times, but it is so operator dependent. The operator really has to be careful about the amount of gain that they put in for the color, because we could cover up all this atherosclerotic disease here by overdoing the carotid flow, the color flow. Now, the other thing I want to show you on this slide, too, is another pitfall. I'm going to tell you that you practically will see no normal slides today in this talk. And there will be several abnormalities on every slide practically. And this one here, you can see this patient has an arrhythmia. So then what's the problem with arrhythmias? You have to decide which one of these things to measure. Do you measure the tallest one? You obviously don't want to measure the lowest one. But when you're looking to get the velocity, which one do you want to measure? Well, I'll tell you the truth, we sort of try to hit something in the middle. That's what we usually do. But that's how arrhythmias can confound velocity measurements. And again here, this is another phase of the routine color Doppler, and you can see there's a color, what they call mosaic, lots of different colors in here like this. And that's the value of color Doppler to help us try to find what area would be the highest velocity to measure for this. And again, this is that same patient has some fairly remarkable arrhythmias, making it difficult to decide which one to use. When it comes to Doppler analysis, you can break it into three categories, and the first one being waveform analysis, the other one being spectral analysis, and the third being velocity analysis. And we rely more on velocity analysis than anything else. But personally, I really enjoy looking at waveform analysis, which tells you a great deal about what's going on sometimes in the cervical carotid system, but often even outside of your field of view, such as in the innominate artery or the cavernous or siphonous portion of the carotid. In waveform analysis, there are some things you have to try to take a look at. One of the ones that comes up quite frequently is tardus parvus waveform. So tardus parvus waveform means that there's a slow systolic upstroke and a slow downstroke. But the end diastolic volume is often increased. In fact, in very bad tardus parvus, it actually looks sinusoidal, which you can see like in some veins. So it can mimic a vein, in fact. And you may wonder if you're in the artery or in the vein. Well, tardus parvus waveform indicates a stenosis proximally, oftentimes out of the range of your view, beneath the clavicle. And if it's bilateral, it can also mean that there's a stenosis as far distal or proximal, I guess you can look at it that way, as the aortic valve and with aortic insufficiency and aortic stenosis. Something similar to tardus parvus you can also see in the common carotid artery, which is a damped resistive waveform. In this case, the peak systolic velocity is under 40, and I think anybody should have some sort of a trigger low number that should just trigger you and say there's something really wrong here. I mean, we're always thinking of, when we're doing carotid ultrasound, we're looking for the highest number, and the really bad things are the really high numbers. But I want to insert in here the idea that a peak systolic velocity in any vessel that you can examine in the neck of less than 40 is a seriously abnormal velocity. And in a CCA damped resistive waveform with a peak systolic velocity of less than 40 and a zero diastolic, and this is where it differs from the tardus parvus, because in the tardus parvus there is diastolic flow. But in this one, there's a low PSV and zero diastolic, and this usually means there's a high-grade stenosis, or occlusion in the ICA. When you see it bilaterally, though, it may also represent low cardiac output, And if you see it in the ICA, and this is rather interesting, if you see it in the ICA, the portion of the ICA that you can evaluate in the neck up to the angle of the mandible, then that may suggest that there's actually a serious stenosis beyond where you're able to visualize, possibly in the cavernous sinus or the siphonous portion of the carotid. And in that case, the patient should have an MRA of the brain to evaluate. Okay, some of the other kinds of waveforms that I find real interesting, we have the Vesperian's waveform. In this case, you have the two normal systolic peaks, but the second peak is higher than the first peak, which is the opposite. Normally in a waveform, you have a high first peak, less high second peak, and then a little third peak. And in between the second and third, there's something called the dichrotic notch, which is actually the closing aortic valve. So in a Vesperian's waveform, the second one is higher than the first one. And this is seen in patients who have aortic regurgitation, aortic stenosis, aortic insufficiency, but it's also seen in hypertrophic cardiomyopathy, obstructive cardiomyopathy. Then you have a very large dichrotic notch. That's called a dichrotic pulse. And so after the first systolic peak, the first two systolic peaks, you have this deep dichrotic notch, and then that's followed by this last peak, the third peak, in diastole. And that's usually seen in patients who have severe congestive heart failure. They have low cardiac output, low stroke volumes, but it has been seen in people who are septic and febrile states. Another one that you can see is what they call sustained systolic peak, which means that the stroke goes up, but it's not really pointed looking. It has a long, flat plateau. And that you see in patients who have systemic hypertension and just generally in older people who have severe atherosclerotic disease diffusely. And then a very worrisome-looking one actually is when you see a reverse diastolic flow in the CCA or the ICA. The CCA and the ICA should not reverse on their flow. And when you see reverse flow like that, that's pathognomonic for aortic regurgitation. As you all know, there are signs that you can recognize in the ECA and the CCA that would suggest that there is an ICA occlusion. The two of them are called internalization of the ECA and externalization of the CCA. What that basically means is that the ECA develops a diastolic flow because it is supplying the territory of the occluded ICA. It's acting like an ICA. When you have externalization of the CCA, its diastolic flow actually becomes obliterated or at least decreased, and that means that it is supplying the high resistance waveform bed of the ECA in the case of an occluded ICA. I'd like to propose that there's actually something called an externalized ICA. And what that is these are the patients we talked about before. These patients have these damped CCA waveforms. You can also get a damped waveform in the ICA without any obvious abnormality in the area that you're sampling. That's a high resistance waveform, and it's seen in the setting of distal stenosis. And again, I bring up the concern for cavernous or siphonous carotid stenosis. And then we talked before, there's something called a sine wave. It's a very damped waveform, but it has to be seen in both the CCA, the ICA, and the ECA. And this one, again, is the one that suggests that you have a proximal CCA or aortic stenosis. But a very interesting condition that can cause this sine wave-looking waveform is in a situation where there is a arteriovenous malformation or in some tumors that are being supplied by the carotid artery in the neck, and also in something known as the persistent trigeminal artery. The trigeminal artery is a fetal artery that is effectively a branch that connects the distal cervical carotid artery to the basilar artery. So it's flowing, it's similar to an AV malformation in that sense, and it has this sine waveform. Okay. So this was out of sync. Well, so here we have an example here of a patient's left external carotid artery, and what seems to be wrong with this left external carotid artery? It has a great deal of diastolic flow, So that alone, you look at that, you see that waveform, you say there must be something wrong in the ICA even before you get to the ICA to look at it. Now what are these things here? This is what is known as temporal tapping. The temporal artery is a branch of the external carotid artery. In order to recognize that you are on the external carotid artery and not the internal carotid artery, the technologist taps at the temporomandibular joint. And the tapping of that temporal artery is transmitted back into the ECA, and that's what we see right here. This is a pretty good example of a spectrum too here. We're talking about here that high peak, the second peak. You don't actually see well the third peak in this patient. As people get more and more atherosclerotic disease, you don't see the typical 3 peaks. Okay, so then here again we've got a patient here, and you can see in this case there's actually, the second peak is higher than the first peak. And so this is a Bispirian's waveform. This is in the CCA, and often you see these Bispirian waveforms more commonly in the CCA. They're better seen in the CCAs. And this was a pre-op patient, a pre-op for coronary artery bypass graft. As I said, all of our patients now get carotid ultrasounds before that. And this patient was felt on his physical examination in his progress notes to have no heart murmurs and a normal heart auscultation. But in fact, after we told them about this, he went on for an echocardiogram, and he did have hypertrophic obstructive cardiomyopathy. And here's another example of it for him. He has a higher second peak than his first peak, and that's in his other bulb. Okay. So now I want you to take a look at this waveform. Anybody have an explanation for this kind of a waveform here? Again, this is, it looks kind of worrisome because you've got this reverse diastolic waveform here like this. This is a really fascinating case, actually. I've got to tell you, this is my favorite case here today. So this is this patient's, what does it say there? I can't read. I think it says it's his CCA on his right. I'm going to show you this is his, whatever that says, ECA. There is his ICA on the right. And there is his vertebral artery. They all look like that. And you say, okay, fine, I don't know, maybe there's something wrong with his right carotid system. There's his left one, and I could show you his whole left side as well, and they all look like that. Does anybody have any idea what that might be? Well, this is a patient that we did bedside in the intensive care unit. That might give you a little clue. He was going for emergency coronary bypass surgery. This is the reflection of his intra-aortic balloon pump back into his carotid system. I think that's pretty fabulous looking. You could actually time it with the machine like that. So obviously we did the whole study. The technologist went upstairs, did the whole study, and then called me. And in the end, I had to say to them that I could only basically rely on the color Doppler pictures because I didn't think any of his velocities were reliable. But this is a waveform I don't think's previously been described. Okay, so now the other thing we look at is spectral broadening. Now what does spectral broadening mean? It's a disturbance of the usual flow, the plug flow that goes through a normal artery, goes in a plug formation. But if you have atherosclerotic disease with irregularities along the wall, that plug flow is disturbed. And the red blood cells flowing in that disturbed flow at different velocities and even in different directions. And that causes a breaking up of the nice, clean-looking waveform that we see. The problem with spectral broadening is that it's extremely operator-dependent. It can be affected by filters used if you have too high of the low-frequency filters. It can be affected very much by the size and the position of the gate that we use. It can be affected by the Doppler gain, and it can also be affected by transducer frequency. But despite all of these caveats, it's still actually a very good clue that underlying there's got to be something very abnormal. So I like spectral broadening very much. Here is diagrammatically, you can see it. Here's a nice normal plug flow. This is what they call plug flow right here. And then it starts to get a little bit irregular when there's a little bit of plaque here. But when there's a major amount of plaque, not only does the flow get squeezed and the velocity gets up, but the blood vessels that get through it at different speeds, and they're turning and twirling as well. So they fill in. There's many, many little, peaks in here, and that's what's causing that Doppler spectral broadening. So now we get to what is color duplex. The combination of color flow imaging and B-mode or Doppler. You know, the machines have a choice. They can only do two things at the same time. So if you want them to do color, you can do color and Doppler, or you can do grayscale and Doppler. So the combination of these is called duplex scanning. In B-mode real-time scanning, in the color Doppler is basically a B-mode real-time scanning, but what we've done is we've taken the Doppler shift of the moving blood vessels and blood cells in the vessel, and we've color encoded them. So it's really important to understand that what it does is it tells you the presence or absence of flow. It depicts the flow abnormalities, and it somewhat depicts the different velocities inside that vessel. But it doesn't, it's still pretty much average flow. You can't truly evaluate a vessel solely on color duplex. I bring this up because there's been some articles recently written suggesting that in large screening programs that all you really could get away with is to just do color duplex scanning of the vessel, and then if the person's color pictures are reasonably normal, you wouldn't need to sample velocities, but I don't agree with that. Anyway, let's talk about B-mode. What's the limitations of B-mode? Well, you actually can't accurately predict the stenosis. If you wanted to spend a lot of time during transverse views of the vessels, and you didn't have vessels that were very tortuous and deep in position, you could probably do diameter measurements. There are programs where you can actually measure the plaque and then measure the whole area of the transverse image, and you can get area decreases. But it's just too time consuming, so it's not very accurate. The other thing is that when you're scanning, sometimes you'll see that, you have to remember that B-mode scanning is still sort of a tomographic scanning. It's not a volumetric scanning. So you can do ultrasound of the vessel, and a plaque can be coming at you from the back wall, and it'll stick in like a tip of a mountain, and you won't really be seeing the whole volume of it. It's too time consuming to try to determine percent stenosis by B-mode. Soft plaque is also very difficult to recognize on B-mode. It can be very dark and the same color as the lumen. You need color flow to contribute to that. Of course, you all know what calcific plaques can do. They can cause shadowing. In our lab, we actually measure the amount of the vessel that we cannot see by underneath the carotid calcification. We try the anterior sternocleidomastoid window, the posterior sternocleidomastoid window. If we still can't clear all of the vessel underneath the calcific plaque, and it's somewhere in the range of 8 to 10 millimeters, we recommend that those patients have an MRA to look under that plaque, because there may be a stenosis still under there that we can't evaluate. And of course, deep vessels are difficult. For deep vessels, you have to change the frequency, and when you change the frequency, you decrease your resolution. So, what about color Doppler now? You have sampling errors. When you're doing color Doppler, you need to make sure that you're looking, when you're sampling the Doppler, you have to be at the jet or just distal to the jet. You need to have an adequate and proper gate. That is, you don't want a really wide gate because it will take in too many velocities on the sides of the walls. You have to place the gate properly. It has to be right in the angle, the direction of the flow of the blood. We recommend that you usually use a gate about 1/3 the size of the width of the vessel that you're dealing with. You have to have proper gain. You want to be careful about high-frequency aliasing. What that means is the pulse repetition frequency is too low for the velocity sampled, and of course it wraps that velocity back around, and you get aliasing, the color aliasing as well as Doppler aliasing. And very important is the correct angle of the Doppler, because what we're dealing with is an angle-corrected number. Doppler velocity is basically a frequency shift. You're sampling the shift of the vessel, of the blood cells moving in the vessel from one location to the next. That's called the frequency shift. And if you use angle correction, then it becomes a velocity in centimeters per second. So the angle is very important. We recommend that you keep the angle between 30 and 60 because that's a more accurate range. And of course, you can influence your velocity measurements if you have your threshold or frequency filter set too low or too high. Here's an example of this. We're talking about the flow. So here's the flow coming into the stenosis here like this, and it's going through it right there. What we want to sample is right there in there, or right just past that. Sometimes these plaques, I don't have a graph to show it, can be very eccentric. And then there will be a bigger plaque, so right here, where you want to sample in the angle direction of that plaque. You don't want to sample always straight within the vessel. You have to sample in the stenosis along its angle itself. Okay, so other technical issues. Well, you may be surprised to know, but this actually is the most common error that occurs technically. The ECA is mistaken as the ICA. Of course, this is a very serious error because the ECAs generally are not treated surgically. And the ICAs are more important because they can have a surgical resection. And if you've mistaken one for the other and said, that a stenosis in the ECA is a stenosis in the ICA, then you're sending this patient to the operating room for the wrong reason. The ECA is identified, as we saw before, by a high-resistant waveform and by a branch in the neck. Again, the ICA has no branches in the neck, and the ECA does. And usually we can recognize at least one of them, even in a high bifurcation, and that's the one called the superior thyroidal artery. Nothing is a better clue that something is an ECA as finding a branch to it. Unfortunately, these things can all be confounded. For instance, the ECA may have multiple branches. One branch might cross over the ICA and look like it belongs to that vessel, and you may mistakenly then call it an ECA. In addition, you may not find a branch on an ECA. It may be difficult to locate. And of course, the other confounding thing, as I showed you already, is that the ECA may take on the waveform of the ICA when there is an ICA stenosis. That's that internalization of the ECA. What we do rely on a lot is this response we talked about before, the temporal tapping artifact. But the ECA, mistaken for the ICA, is the most common error, and it accounts for 25% of all errors in scanning technique. There can be a reversal of the normal position of these. That happens only in 5%. We talked about the fact that you can have internalization of the ECA in the situation of an ICA stenosis or occlusion. The ECA can be evaluated twice, and I've seen this done, where we've gone in, you can't sometimes get them both to show up on the same image. You get one and then you get the other, and you sample one and you sample the other. And you think you're sampling the other one, but you're sampling the ECA again, and that can occur as well. And as we said before, a branch of the ECA may be mistaken for the ICA, particularly when the ICA is already occluded and there's lots of collateral vessels. So here is a graph. Basically, you're looking at the patient from the right here like this, and you can see that here you've got the internal carotid coming up here and the external carotid with its branches coming off here. And I can't see this very well, but you can probably see this is the origin of the subclavian. This is the origin of the vertebral artery off of the subclavian artery, and over there behind that we've got the left side. Okay, so what have we got here? Is this temporal tapping? We're looking at this case right here, and there seems to be this consistent little beep, beep, beep thing here like this. Well, you're lucky because this is already labeled for you, and that says it's the CCA, but it does look a little bit like temporal tapping. But remember, this is not in the waveform itself. This is a noise that's in the baseline of this. In our ultrasound lab, we had the operating room above us being rebuilt, basically, and we were getting a lot of interferences for a while there while they were doing work. Some of it may be electrical interference, and some of it just being noise. Just vibration can cause this. But also this can be happening, I've seen this not infrequently, in patients that are sort of quietly swallowing or clearing their throat, and you'll get noise picked up into the waveform as well. But here again, this is that patient I showed you before. He has two things. He's got temporal tapping, which is just a beautiful example of, so we're going to rely on that, but that's the ECA. But he has internalization. He has high diastolic flow in the ECA. This is not a typical ECA flow. So you know from looking at those two things, you've got an ECA, and you've probably got a very bad disease in his ICA. Okay, other scanning errors. The ICA can be not seen and assumed to be occluded, but it's actually deep and you need a lower frequency transducer, and you're just observing a little fragment of it, and then it dives deep, and you think it's finished. Partly, the reason why you think it's occluded is because when it takes that deep dive, it's in another plane. Not only is it deeper, but it's no longer in the plane. It's not in the transverse plane of your transducer. There are high bifurcations that are very difficult to evaluate. When they get up above the level of the mandible, and sometimes you can only see about 1 centimeter of branch vessels. And then those patients really need an MRA. You have these tortuous vessels, and sometimes you have trouble following them. You're following them for contiguity and for continuity. You're trying to decide where does it move when it takes those little curves, and you may miss a section of those, and then in that section you may have a stenosis. And again, you have to make sure that you are sampling all around the area of the stenosis. I mean, our techs usually take 4 or 5 different samples around an area of a stenosis and try to get the highest velocity. Now here's a case of a patient who's very confusing looking. He's got lots of things going in every which way in all directions. He's got another one down here like that. And these are the kind of patients who sometimes are just so confounding you can't really come to a decision. This is his MRA, and you can see the number of tortuous vessels and branch vessels that he has with his associated ICA stenosis. So, but basically, velocity is the primary criteria that we use to determine stenosis, because there have been criteria that have been developed that correlate well to the gold standard, which is angiography. Now, I don't really want to get too deep into that controversy. As you all know, there's probably been 12 or more tables of velocity measurements to correlate with degrees of stenosis. And in fact, I Xeroxed ours, and it's out on the table out in the front there. We have 2 tables on there. We have the old table that we used, and then we have a newer table that was agreed upon by the Society of Radiologists in Ultrasound last October. And what they did is they stuck a category in there to try to make it tighter around that critical point of 50 to 69% stenosis. Because in that category, as I said before, we're talking about people who might benefit from endarterectomy. But we have found from our own studies, and we've published as well, that within the same lab you can have discrepancy in velocity measurements between one tech and another tech, depending on how they sample, between one machine and another machine, even a machine of the same manufacturer, of the same year, of the same model, in different rooms. So you really need to do that yourself. You have to do your velocity measurements and then correlate it to angiography. We have still a very large ongoing NIH grant, so we had the time and the facilities to do that, to see and to find out that between manufacturers there's a problem, even within manufacturers there's a problem, between techs there's a problem. And we had to learn how to correlate our data to come to the correct percentage stenosis based on angiograms, which, by the way, we rarely do any neuroangiography anymore. We do almost all MRA angiography. So. And our surgeons do surgery now based basically on carotid ultrasound, unless there is a problem with, and we identify the problem of the carotid ultrasound, and we recommend an MRA, such as having a large cuspid plaque or having a very confounding picture. That doesn't mean that they're being cavalier, because we're pretty cautious. If we're not happy with the carotid ultrasound, we do recommend the MRA rather freely. Okay, so velocity, as I said before, is an angle correction of the frequency shift data. And in the extracranial carotid ultrasound, stenosis is based mostly on peak systolic velocity, not luminal narrowing. That is, we don't rely on color Doppler or grayscale. But the other thing you need to know about that is that all these wonderful charts that we have, these are basically been built up for the ICA only. And then a good way to point that out to you is that, you remember, the ECA has supposed to be normally 0 diastolic flow. Okay, so these charts always have some diastolic flow. These were not built for CCA and ECA. We do apply them. I'm not saying we don't. We apply the same criteria to those two, but it's probably not a correct thing to do. So, as we said before, the criteria have been matched to angiography, and some pitfalls can include technical issues and intrinsic diseases or anatomical variants, like that persistent trigeminal artery. So we need to talk a little bit about Doppler angle. I'm sure you've all heard about this before, but the big issue of it is this, that at low degrees of angulation, angle of inclination, if you have a 5-degree error, that is that your technologist maybe should have put it at 30 degrees, but they put it at 25 degrees, or vice versa. There's a small error change because with the formula that changes frequency shift to velocity, the critical step is the 1 over cosine theta, theta being the angle. And the error change is small when you're at 25 to 30 degrees. That is, it would be 1.1, the 1 over cosine theta would be 1.1 at 25 degrees and 1.15 at 30. So staying to that lower end is a safer way to be. When you get to higher angles like 80 to 85, then the difference goes from 5.76 to 11.47. A minor 5-degree difference in change of the angulation results in a very large difference in 1 over cosine theta. So we try to keep the angle less than 60, and some people even recommend that you set your angle at 60 and try to get the vessel to comply. That is, you try to set it there and try to angle at the vessel with the transducer so that it fits in that 60 gate. That doesn't always work very well, but we try that. I have to say that when it particularly doesn't work well is when we do the intraoperative carotids because they're flat. We're just scanning right on top of the vessel itself in a pool of water, so it's kind of hard to get a correct angle there. And in fact, we don't rely on velocities in the intraoperative carotids. That's one thing I should say is a true exception to the rule when it comes to evaluating carotids. Intraoperatively, we're not really looking at velocity changes. We're looking at luminal abnormalities. And I've got a number of things to show you at the end. In practice, B-mode imaging is best done at 90 degrees. You can actually see the vessel plaques more distinctly at 90 degrees. So we have to compromise. So we always try to be between 30 and 60 degrees. Okay, velocity errors. You've probably all heard that in high flow states like hypertension and hyperthyroidism, you can overestimate velocities. In low flow states like congestive heart failure, you can underestimate it. Sometimes you see a 90% stenosis, but by the time the patient gets to surgery or an angiogram, he's occluded. So that's what they call gradual stenosis. You can have moderate stenosis in a large bulb, and you may underestimate it because it now has a lumen that looks like the rest of the vessels. This is particularly pertinent in the NASIT studies and things like that because what they did is they took the diameter measurement of the area of concern and compared it to a distal, supposedly normal region of the artery's diameter. But with the bulb being larger, you could get a 1-to-1 ratio that way and still have moderate stenosis in the bulb. And obviously we talked about tortuous vessels and deep vessels where you have trouble getting a good angle correction. So again, the 3 major things is you've got to sample in the area of the maximum velocity. You've got to have a good angle of inclination of 60 degrees or less. You have to sample in the direction of the plug flow or the flow of the stenosis itself. You have to be in the direction of the stenosis itself. We talked about all those things, including the arrhythmias. Okay, again, here's an example of terrific arrhythmia issues. Very bad and terrific spectral broadening. The other thing is tandem lesions, and I basically referred to that before. That is the velocity of one lesion proximal to another lesion. It can be spuriously decreased by the distal lesion. And an example of that is what I talked to you about, the carotid or siphonous carotid disease, which can dampen the PSV in the cervical carotid. So your clue to that is there's a big discordance between what you're looking at. On the B mode, it looks like a bad stenosis, but your velocity does not match it. And the clue to then when you see that, you say, my God, there must be something else going on. Well, there is. There's something in or out, above or below, invariably, the area that you're looking at. And frequently it's in the carotid siphon, and it goes unnoticed, unknown. So then the other thing is something called the pseudo-occlusion or the string signs. As I alluded to this before also, that you have to be very sensitive to the possibility that there's still a tiny bit of flow in an area that looks occluded. Because that, if you call it totally occluded and you don't feel really comfortable about it, the patient won't go on to MRA and will not go on to surgery. One trick for that is to go up as high as you can and see if beyond that occlusion you can find any flow, okay? Because since this internal carotid artery has no branches in the neck, there's nothing that could supply it beyond that stenosis except itself. So you have to try to fix everything to see that flow as best you can. You spend a lot of time on that. And what I suggest you do in the color Doppler mode is you drop it into venous mode like you would do for a DVT ultrasound. That drops out a lot of the filters and is looking for slow flow. Of course, power Doppler is very sensitive to flow or no flow, but in the long run, if there's any suspicion in your mind, the patient should get an MRA because it may maintain a surgical candidacy. Okay, so again, you've probably already heard that, if you have a very severe stenosis or occlusion in a contralateral vessel, in a vessel, the contralateral vessel, we have elevated velocities, and that's related to compensatory flow across that vessel, across the ophthalmic arteries to supply the other side. So compensatory flow from a severe stenosis can actually increase velocity, and then you've got a disconnect again. You're looking at a vessel that doesn't look so bad, but it has high velocity. That's a disconnect that you have to say there's something wrong here. So even in cases where velocity measurements appear normal, abnormalities in the spectral waveform, in spectral broadening, in grayscale, in color, any of these other things, can suggest that there is the presence of a stenosis or disease within the scan area or even outside the scan area, or the presence of anatomical variants, which I talked about before. So abnormally low resistive waveforms can be seen with anatomical variants, which I talked about before, which include this persistent trigeminal artery. And actually in these cases, sometimes you can just drag up you can take a look at the resistive index. And the resistive index in the vessels, normal is 0.7 to 0.9. If you have a low resistive index of 0.4, then you have to believe there's something else going on. And frequently there's one of these anatomical variants involved, like an AVM or a trigeminal artery. You will not recognize the trigeminal artery. I've never been able to Doppler one, but you can get an MRA and see that. And it is a fetal variant that basically bridges the internal carotid artery and the basilar artery territories. Okay, and then of course you can have inaccessible stenosis, which is one of the things I keep harping about, which is the cavernous sinus disease. Again, we talked about this pseudo-normalization of stenosis. When you get to a stage of 90% stenosis or greater, some people say 95, the flow is so restricted by that thin little area that it has to go through, that little pinhole that it has to go through, the velocities actually drop. And again, I bring up this idea that if you have a peak systolic velocity of less than 40 centimeters per second, there's something distinctly wrong with the vessel. And in these cases, actually, with pseudo-normalization at greater than 90%, often it looks sinusoidal because the diastole doesn't drop, but the systole does drop. When you have carotid dissections or you have a long stenosis, you can get normalized velocity in those chambers, actually. And so the velocity cannot be relied upon. And we already talked a bit about diatartus parvus, which if unilaterally you think it's a proximal obstruction, but if you see it bilaterally, you believe the obstruction might be at the aortic valve itself. And this is a graph that shows that issue about patients' velocities. Basically, the flow cutting off. Basically, when the velocity gets high, and this is about 95% stenosis, then the flow stays persistent until that stage, and then it drops off. And when the flow drops off, your velocity drops off too. This is another schematic to that effect. And you get high velocities, and then it just drops down to these little velocities here. So here is a case, you've seen some of this before. Here's a person who has the external carotid artery and high velocities in it, and he has the high diastolic flow suggesting that there's a stenosis. And then we've got extreme spectral broadening here in this patient. And then you look at this vessel and you say, well, it doesn't look altogether that bad. Why does it look like he's more stenosed than he is? He does have that nice plaque back there that shadows out, which you have to avoid when you're scanning. You may have to take another window to get around it. In fact, here's his MRA. Doesn't look that altogether bad. Not to say that it's totally normal, but he's got pieces here, but he doesn't look terribly stenosed, not to the extent that his Doppler tracing looks. Clue, that says to you there must be something wrong then with the other side. And I put this slide in too because I wanted to remind you, and I always bring this up to the people that read the MRAs, that when you've got those cine MRAs, they only pan 180 degrees. So that MR angiogram I showed you, it rolls to this side and it rolls to that way. It doesn't go all the way around. I think that's a pitfall for MRA. You might see something if it could go more 360 degrees around. So here's that patient's left side that we're talking about. Again, we have terrible arrhythmias. You might notice he has this diamond-shaped reverberation sort of shape here to his Doppler waveform, and that is what some people term the thump of the stump. That is, those red blood cells went up, hit something, and ran back. And so when you see that reversed flow in the systole part, now, previously I talked about reverse flow in the diastole, which is associated with aortic regurgitation. This is reverse flow in systole. Okay, so that's serious. And that's because he has aortic internal carotid artery occlusion here. And you can see here again, he's got one vessel only coming off here like this. I'm afraid I'm running out of time. I've got to move faster. So before I finish, I wanted to show you a few of our other good cases here. We have this case here where you see the common carotid artery is occluded. We've got the ECA and its branch basically supplying the ICA here. And you can see the flow in the, going across into the ICA. It's actually a TARDIS looking flow because it has a proximal stenosis because this entire ICA is occluded here. And you can see there's flow coming back around and filling it up through the ECA. The ECA flow is reversed below baseline. Temporal tapping you can see in there as well. Temporal tapping also here in the distal ECA. And that's what that looks like. Here's when it looks like a bifurcation. This is where things can be not what they seem. And this one looks like you've got a bifurcation here like that, and you've got, one vessel and two vessels. But in fact, this is the end of the ICA right here. And that other one is a large ECA collateral. So you may think, oh, how could anybody, name an ECA branch and ICA? Well, I think that's a good example of how it can be done. Here's another patient here, and you may look at this, it's very straight lined and all that, and that's a graft in this patient's common carotid artery, the one I just showed you that has the ECA occluded. This is CCA. The CCA is down here, and this is a graft that goes from his subclavian artery up to his bulb. You don't see too many of those. You can see that right here. It's a very nice example of it. Here's his graft right here like that. And if I give you the next picture, you'll see that he has the graft in here like this, and he's occluded on his other side, on his ICA side. So they really do those things, but they do it in his situation because he has an occlusion. Quickly, I wanted to show you the vertebral arteries that are pre-steel. They have an appearance like this. This is known as a squirrel pattern. He has a reverse flow, long tail down here. That's a squirrel. Whenever you see a vertebral artery that has a strange waveform like that, make sure, first of all, you're in the vertebral artery because the vertebral vein can have a very strange waveform. And the vertebral vein is anterior to the artery when you're scanning. And then this one here is called the rabbit. And he has high ears and a little tail. And either of those two patterns suggest the patient has vertebral subclavian artery disease and he is in a pre-steel state. And here's an example of a nice calcification at the origin of the subclavian here and in the common carotid like that. And sometimes you can get deep down into the supraclavicular fossa and actually see some of these subclavian diseases that can cause the steels. Okay, this is another graft postoperatively in a CCA. Here's another graft postoperatively in a CCA. And here's a color Doppler of that. So they do rather unusual things in our surgical suites. Now this is the last one I want to show you, and this is a picture of an intraoperative ICA. And the reason I want to show you this is because this was, the patient's neck had not been closed. And you see all of this sort of grayish stuff around the lumen of that. That is thrombus developing. You see the thrombus developing right in there in this patient's internal carotid artery endarterectomy site. And I just want to remind everyone present here that the treatment for this disease is a thrombectomy. And if a patient develops any new neurological symptoms in the first 72 hours after an endarterectomy, the treatment, the standard of care, is to have an endarterectomy done and this thrombus be removed. And to see it happening right before your very eyes in an operating room is pretty amazing. They did go in and they did clean out this thrombus, and the patient did do well. But these are the things that we're looking for when we're doing intraoperative ultrasound. We're not looking for velocity measurements. I think we play a very important role intraoperatively looking at these things, because this would be silent until the patient clotted this entirely off and probably clotted off his entire middle cerebral artery and all that. And if we can find it intraoperatively, we can take care of the problem right away. So thank you very much.